My name is Johannes Pulskornberg. I'm an assistant professor of neurology at the Keck School of Medicine at USC, and I'm here to answer some questions. So question number one. You're caring for a patient in the neuro ICU for loss of consciousness after 3 seizures within a 2-hour period, eventually leading to intubation for airway protection. She's sedated with propofol, loaded with 2 grams of Keppra, and received 2 milligrams of Ativan prior to intubation. Which of the following symptoms on exam suggests that the patient is actively having non-convulsive seizures? So I would say, first of all, the question should say signs on exam, because a symptom is something that the patient tells you, and a sign is something you elicit, but that's not really what the question's asking. So new onset pupillary dilatation, yes. Elevated CK, unfortunately, anyone who has a convulsive seizure will have an elevated CK, so that's not particularly specific for ongoing seizure. Upgoing plantar reflexes, you can see that either ictally or post-ictally. It is also non-specific to seizure itself. You can have that from diffuse cerebral dysfunction. New onset hypotension is pretty common after you get either intubated, get Ativan, or get propofol, so lots of drugs can cause that. So I wouldn't necessarily think that hypotension can be useful. Sometimes hypertension can be useful, but definitely the new onset pupillary dilatation is the most specific out of all the answer choices. So that's the correct answer. Question 2. A 70-year-old man presents to the emergency department with a history of fall and loss of consciousness. CT brain was performed, revealed a large left-sided subdural with uncal herniation. What complication of rapidly developing brain herniation is shown in the provided images? So obviously there's a large left-sided subdural hemorrhage, looks pretty acute. However, if you scroll down to window C, you can see that there's also a pontine hemorrhage as well. This is called a Duray hemorrhage, which is answer choice C. That can be caused most commonly by sudden herniation, but is not specific just to that. If you ever see someone with new onset brainstem symptoms with someone with subdural, that's something to consider. Aneurysmal rupture, of course, would give you subarachnoid space hemorrhage. Diffuse axonal injury is something seen with severe trauma. When I say severe, usually like very severe, like high frequency, high velocity motor vehicle accident, and usually not a fall from standing. Hypertensive hemorrhage wouldn't be subdural, would be usually intraparenchymal. And hypoxic ischemic injury could give you diffuse cerebral edema, but wouldn't tend to give you a subdural hemorrhage. So definitely Duray hemorrhage is the correct answer. Question number 3. A 25-year-old man with a history of polysubstance use disorder presents with confusion and is assessed with the MRI shown. What is the most likely diagnosis? So looking at the MRI, it's a DWI sequence, and you can see that there's abnormality in the bilateral hippocampal tails. This is almost diagnostic of transient global amnesia, but in the question STEM, note that they say confusion, and that's really not specific. So transient global amnesia, I wouldn't even categorize as confusion. It is a very specific syndrome of severe anterograde amnesia, so severe that the patient will ask you the same question often every 2 minutes to every 5 minutes, where they literally cannot form new memories. They frequently will also have retrograde amnesia as well, sometimes for a few days, few hours, or even a week prior to the onset. Interestingly enough, these lesions, even though they look almost like stroke, are reversible. We don't really know what causes TGA. It's been thought maybe it's a form of epilepsy, maybe it's a form of reversible ischemia, but the fact is we don't really know. It doesn't tend to correlate with vascular risk factors either. It can recur, but it is actually not very likely to recur either. Concerning the other answer choices, so acute basilar artery occlusion, God forbid if you had a large basilar artery stroke, you would see stroke in other structures besides just the hippocampi. Anoxic brain injury usually gives you DWI signal in the deep structures, so basal ganglia, caudate. Chasing the dragon is a form of a toxic leukoencephalopathy. It doesn't have to be specific to opiate use or chasing the dragon, but any toxic leukoencephalopathy will give you diffusion restriction, not usually of the gray matter, but usually the white matter of the subcortical regions. And then TGA, I actually had a case of TGA in my residency where instead of being quite as large as this, it was a kind of a one punctate dot in one of the hippocampi tails. So it can be pretty non-specific, or it can be very tiny. It doesn't have to be bilateral, it can be very small, and certainly you can have a normal MRI as well. All right, question 4. According to practice parameters by the American Academy of Neurology, which of the following is not recognized as a reliable assistive device in accurately predicting a poor outcome in comatose patients after cardiopulmonary resuscitation for cardiac arrest? lack of pupillary response at 3 days, lack of corneal reflex at 3 days, serum NSE greater than 80 micrograms, diffuse bilateral cerebral edema on CT head, or myoclonic status epilepticus in the first 24 hours. So the correct answer here is diffuse bilateral cerebral edema on CT head. The lack of pupillary response and corneal responses at 3 days is uniformly a poor prognosis. Generally, when you don't have cranial nerve reflexes that far into an anoxic event, that's not good. Serum NSE is something that I've actually never been at an institution that utilizes NSE because it usually takes too long to come back for you to make any kind of reasonable prognosis with it. But technically, it is in the guidelines. Myoclonic status is an interesting one. So although it is taught that myoclonic status is a uniformly poor prognosis, you can actually find case reports where people have had better prognoses with myoclonic status. And so I personally no longer say that it is uniformly a bad prognosis. Now, in contrast, diffuse bilateral cerebral edema on head CT can be reversible if it's not true infarction. Also, things like severe hyperammonemia can cause cerebral edema or status epilepticus. But usually if you have diffuse cerebral edema, it usually portends a poor prognosis, just not uniformly poor prognosis. Question 6. You are caring for a 19-year-old male in the neurocritical care unit after drowning. His brain MRI is pending clinical stability. Which of the following findings on brain MRI is most likely to be shown after a severe global hypoxic injury? Bilateral watershed zone hyperintensity, bilateral basal ganglia and thalamic hyperintensity, periventricular hyperintensity, hyperintensity along the gray-white border, or hyperintensity in the corpus callosum. So the answer here is usually diffusion restriction in the bilateral basal ganglia and thalamus bilaterally. The reason here is because these are gray matter structures, and gray matter structures tend to be more metabolically active and therefore tend to be more affected when you have global anoxic injury or hypoperfusive injury. All of the other answer choices are involving white matter or gray-white borders. Incidentally, this can also mimic Creutzfeldt-Jakob disease. But obviously in a 19-year-old with drowning, you're not suspicious for Creutzfeldt-Jakob. But sometimes when people are found down and you have no idea what's happening and you just get an MRI, you sometimes can't know if it was an anoxic event or if they had CJD and they just maybe had a seizure or something else happened. So consider both, and the MRIs can look very similar. Question 7. An unresponsive patient with an ischemic stroke is transferred to the intensive care unit. On physical exam, the patient has flexion of the bilateral elbows, wrists, and fingers, but extension of the legs. Where is the stroke most likely located? So this question stem is describing a decorticate posturing. The way I remember it is decorticate is the one where your arms are near your core here, whereas decerebrate is the other one. And decorticate posturing involves preservation of the red nucleus and the rubrospinal tract. So you know that the lesion should be above the red nucleus. The best answer here is thalamus. Other lesions will give you potentially decorticate posturing if you interrupt the red nucleus, and that involves extension at the elbows, this posture, as well as straightening out of the legs. Question 8. An abnormal breathing pattern described as an initial prolonged inspiratory phase, inspiratory pause, and then incomplete expiration can localize to damage of which of the following regions along the neuraxis? Cerebrum, cervical cord, pons, midbrain, or medulla. So first you have to ask yourself, what kind of breathing pattern is this? At first glance, it kind of feels like Kussmaul because you have a large inspiratory phase, but then the inspiratory hold and an incomplete expiratory phase is characteristic of apneustic breathing. Very rare and associated with pontine damage. The difference, of course, from Kussmaul is that you don't finish the expiration. Also, Kussmaul is associated with something like DKA, whereas this is more specific for pontine damage. It's also different from Jane-Stokes because Jane-Stokes should have kind of big breaths and shallow breaths and big breaths again, whereas this is large inspiratory draw, then a pause, then short expiratory, and then back up to inspiratory. So pretty unique in the grand scheme of things.